celebrating our 20-year anniversary, still strong and going. We do education, advocacy, and thought leadership around healthcare and innovation. And today is one of the topics we're going to talk about related to healthcare innovation. Next slide. If you don't know who you are, this is or who we are, this is a group of the leaders involved in our initiative in Washington. If you don't see the name of your organization listed up there, we want to see you join our group. We welcome everybody to the big tent of eHealth Initiative, and we'd love to have you involved in our activities. So go ahead and reach out to me if you'd like through the chat room, and we'll get back to you. We take everybody, payers, providers, labs, vendors, academics, anybody who wants to be involved across the spectrum of healthcare. We want to hear your point of view, because healthcare is really an interconnected system and we've all got to work together on it. Go to the next slide. We work primarily on 4 critical issues right now. Privacy, virtual care, which we're going to talk about today, social determinants of health, analytics, and of course, COVID-19. We've been focused on COVID for the last 10 months here, doing a lot of important work. If you go to the next slide. We've done a lot of educational forums this year, and we are a nonprofit, so these are available free of charge on our website right now. These are a few programs that we've done this year around remote monitoring, telepsychiatry, pandemic, how it's influencing consumer behavior, a whole slew of sessions around telehealth and reimbursement policy. It's really important not just to do virtual care, but get paid for virtual care. And then privacy, which is, I think, top of mind for so many of us right now. All of this virtual care results in a lot of questions about how's the data being used, is it being used appropriately, and how is it being protected and secured. Next slide. And we've done a number of publications this year related to COVID, which I also encourage you to download in our resource center, ehidc.org. Most recently, we've come out with a wonderful paper about the ethical use of social determinants of health data during COVID-19. We've done a lot of work around supporting American Indian and Alaska Native communities combating COVID-19. A lot of work around telehealth and how that's getting to those communities there, and virtual care, supporting communities that are rural and out of the area. And then we've done a lot of work around federal policy as well, and how that needs to change to really adapt to this virtual care environment we're in. Next slide. So coming up, we actually have a couple good programs I'd love for you to think about. Diversity in clinical trials will be on January 12th, and we'll also be talking about surveilling COVID-19 January 20th. We've got a fabulous EHI annual member meeting planned for January 26th to 28th. So for all of these events, I encourage you to jump onto our website and register for them. Most of them are free of charge, with the exception of the member meeting. If you're not a member, there is a small charge for that. Next slide. Okay, here's the thing everybody probably knows by now. I think we're all Zoom acclimated, but if you're not, we are currently muted. You have muted yourselves. You can't unmute yourselves. If you have a question, you can raise your hand. The easiest way to get your question answered in that Q&A box at the bottom there is to send your question in there, and we will get to as many as possible at the end of the program today. Next slide. Okay, and I am delighted to just thank Conversa, who's done a heck of a lot of work on automating virtual care, which is the topic we're going to talk about today. Really, I think you're going to really be delighted with the conversation today. But I do want to thank them. As I mentioned, we are a small nonprofit, and we would not be able to do programs like this, educational programs, without the support of groups like Conversa. So I do want to thank Conversa for supporting the program today that we're about to start. So let's go ahead and go to the next slide. We've got an incredible panel. So I'm going to just introduce the panel here, and then we're going to go ahead and just jump into the discussion. We have Dr. Peter Pronovost, who's the Chief Clinical Transformation Officer at University Hospitals Health Systems, which is an 18-hospital health system which is based in Ohio. We have Dr. Nick Patel, who's the Chief Digital Officer and Vice Chair for Innovation and Clinical Affairs, the Department of Medicine at Prisma Health, which is also an 18 hospital system and South Carolina's largest employer. So we're hitting all parts of the country here today. We have Mr. Murray Brzezinski, who's the CEO of Conversa Health, which is a leading automated virtual care tech company, and Dr. Aaron Einstein, who's Associate Professor of Medicine way out on the West Coast, UCSF Endocrinology, and Director of Clinical Informatics at UCSF Center for Digital Health Innovation. So a big welcome to all of our folks here today, and let's just pull everybody up on screen here if we can, get rid of this slide. Great. So welcome, gentlemen.
Great to be here.
Welcome, Jen.
Thanks,
Great.
Jen.
Thank you.
Glad that everybody's here today. So Murray, let's start with you. So let's get the conversation rolling on virtual care and how this has kind of evolved over really, I would say, a lot of adoption over the last year. And I know you've worked with health systems and life sciences, payers, really across the healthcare landscape. Set the stage for us a little bit in terms of today's discussion. Where are we at right now with virtual care?
Yeah, first of all, thank you, Jen. And it's a pleasure to be here with Peter and Nick and Aaron. Really looking forward to this. So just to step back, if we go back in ancient history before COVID, 12 months ago, we all know that we were as a country, trending towards spending 20% of GDP on healthcare, which is not sustainable. We have middling outcomes. We have capacity problems at all our health systems. We've got access problems, and poor patient experience, and our providers are highly burdened, and many of them experiencing burnout. So all of that existed before COVID, and I would suggest that all of us would probably agree that COVID has really laid all those issues bare. It's really exacerbated them. It's highlighted the need to be more urgent around fixing the problem. And virtual care has always been on everybody's radar. There's different levels of investment and experimentation and implementation, and that's now all been accelerated because it's impossible to conceive of solving those problems without making those investments and really dramatically changing the way we do care delivery. So virtual care is a term that's thrown around. It means lots of things. I think about it for this conversation kind of as an umbrella term. And when we talk about virtual care, we're talking about space, time, and people, right? So if you think about it, the first step was really, can we actually have patients and providers interacting, but do it in a place where they're not physically in the same space? And that's really what telemedicine is all about, right? So you still have a synchronous connection between a patient and a provider, but they're at a distance. And that can be done through audio, can be done through video, can be done through both. And that's been a wild success as we've experienced through COVID, is the utilization of telehealth has come up dramatically. I see you put the slide up here. So if you I'll kind of just describe a few of these and then talk about the automated piece. So the next piece is really addressing time. And time is, how do you have the patient and provider interact where they don't have to be synchronously together? And that addresses lots of problems. It opens up lots of capacity. And that's really what e-visits and virtual check-ins are all about. So you can have recorded video, you can have texts, you can have recorded phone calls, and the patient and the provider can communicate back and forth either to set up an in-person consult or in many cases to actually have the consult, and it's reimbursable and all that. So that's wonderful. And as you move further to the right, we're moving from synchronous to asynchronous. We're moving from high cost and higher barriers to access to asynchronous and lower cost. If you start to move to remote patient monitoring and automated virtual care, what you're starting to do is we addressed space, we addressed time, now we're addressing people. How can you introduce automation, which is another huge trend in healthcare, to the virtual process? So now you can actually have computers and artificial intelligence systems interacting with the patients and collecting valuable information and making decisions, in many cases, about how to keep the patients healthy or improving in their care in a fully automated way, and then collecting enough information to make decisions about when those patients need to be intelligently triaged to the higher level of care. So this isn't a trend that's moving from in-person to automated virtual care. What it is a spectrum of care delivery models that all work harmoniously together. And I would, put out there that this automated virtual care, because it's the most asymmetric, it's the lowest cost and the lowest barriers to access, can be sort of you can envision a future where it's like the flipped classroom in education, where everybody is on these automated programs. And when they need to get that higher level of care, they're automatically and intelligently triaged to in-person visits through scheduling systems, to e-visits and virtual check-ins, to telehealth visits. And it's a dynamic where the patient is going through a journey back and forth through these different care delivery models to get them to the right place at the right time, get the best outcomes, but do it at the lowest cost. And to make this work, and the final setup here is the lifeblood of this kind of a model, care delivery model, is data. You can't do this without having a full view of the patient. And the only way to do that is to be able to take all of the data that we know about the patient from clinical systems like electronic health records and combine it with data that we can collect from the patient, the wisdom that we all carry around with us. So anything you can collect from a sensor, right, any kind of monitoring information from the patient's biology, and then also by asking the patient, so patient-reported outcomes. And then you need a system that can take all that information and make decisions in real time to determine whether the patients can be kept on an automated pathway or whether they need to be triaged to one of these higher levels of care.
Murray, I'm going to just push you just a little bit to dive a little bit deeper so people can understand this term automated and asynchronous. So synchronous is when you're getting care kind of live, real time, maybe video care in person, right? And asynchronous would be
asynchronous would be I send you a text, you're my doctor, and then you get back to me later in the evening. Or I record a message or take a picture of a wound and I send it to you, and then you get back to me at a time that's convenient for you.
Okay, so this whole spectrum, we're kind of moving from these synchronous live in-person visits to more and more asynchronous, but these are all tools from what you're saying that work together. One's not better than another.
Absolutely. What's happening now, and I think Peter and the others will talk about this, there's a lot of waste because we're using certain care delivery models that are overkill and not necessary. And on the flip side, there's not enough money or people in the world to be able to reach out on the frequency you can in an automated way to collect data to have better insights into how patients are doing. So you're actually getting a unique situation where by applying this in a smart way, you can get way better outcomes because you can start to predict decline, more quickly, earlier. You can stem the complexity of disease, but you can do it at much lower cost. Usually you have a trade-off of cost and quality, and here you actually get both.
Okay, and so the term automated really means that all of these different tools are kind of plugged into the process to happen at different points.
Well, the automated, I'll end on this. Yeah, the automated part, it's an important part, is unlike other industries where I think it's true in some parts of healthcare where automation literally will replace people completely. I think that's true in some manufacturing settings and others. In healthcare, what we're seeing is it's more augmentation. It's more offloading activities that are better done by AI systems and freeing up providers to practice at the top of their license. And I love this quote. I'm sure a lot of people are getting hooked. I got hooked by the Queen's Gambit, so big chess. And I'm using chess analogies these days. Yeah. So Gary Kasparov, who's a grandmaster, makes this distinction between computers and people, AI and people. And he says, AI is really good at making decisions because it's computational all the way down. And humans are really good at making judgments. And it's sort of like humans are asking the questions, AI is, finding out the answers. It's that partnership that ultimately makes the automated, because the way I described automation, as you just heard, it's determining when a patient actually needs to be connected to a care team member, and only then does it make the connection. So the care team member can focus on the patients that need them, when they need them, with the data, so they have the context of the situation to provide better care.
Great. So that's a wonderful background. So let's jump over to our panelists today who really all represent different provider organizations across the country that are using all of these different tools, synchronous all the way to asynchronous tools currently right now. As COVID-19 has struck the country, a lot of this virtual care, we've all been leveraging it in different ways. So let's talk about some of the different institutions you represent here. So Dr. Neinstein, let's start with you at UCSF and talk a little bit about what you guys have been doing there, which of these tools you've been using. Go ahead.
Yeah, thanks, Jen. And thank you, Murray, for the great setup for how we're thinking about virtual care. I completely agree that we've built a healthcare delivery system where the default pathway is the most expensive and the most frequent use of our most expensive resources, which are our providers, rather than using lower cost tools for lower complexity activities and then pulling the information when necessary to those high cost resources. So there are two main places over the past several months where we've been leveraging more automated care pathways. So one is around employee screening for COVID, and the other is in virtual chronic disease management, highlighted by the work we've done with our lung transplant program. So I'll spend a second talking about each of those. So around employee screening, San Francisco was one of the first places to have COVID patients in the country. And so the second week of March, a health order came down from the city and county mandating within about 48 to 72 hours that all healthcare facilities start screening our employees, tens of thousands of employees, for COVID symptoms and risk factors before coming into work every day. And so day one, we had lines of nurses around the corner, 30 to 40-minute lines to get into work as we started trying to screen people at the door. And so we working with Conversa, we deployed over the course of about 7 to 10 days an automated screening tool that allowed employees to get a text message every morning, answer some basic questions, and rapidly get into work using sort of like a TSA pre-check barcode that they could get into the hospital and get into work. So saving just absolutely tons and tons of hours of employee time, staff time, and energy, preventing people from coming into work sick. And, same basic principle underlying here is these are very basic questions to ask that need to be routine, standard, automated every day. And asking that to be done by a person-to-person interaction just makes no sense. It's a very simple thing to be automated. And then, of course, if someone actually does have symptoms, they get kicked out to talk to our occupational health. And so the person-to-person, expensive, high-touch interactions only happen when needed and not as the default. The second example is starting to move some of our chronic disease management. Obviously, a lot of chronic disease across the country was getting deferred over the spring and summer by people who were rightfully so very anxious about coming into healthcare facilities for fear of COVID transmission. One of those really high-risk groups is our lung transplant program. So UCSF manages just under 500 people who have had lung transplants, which actually makes us one of the largest programs in the country for lung transplant. And obviously, amidst a respiratory pandemic, there's a group of individuals who are rightfully very anxious, concerned about leaving the house, and concerned about their lung function and the survivability of their transplant. So we built a program to try to provide them with peace of mind, and with continuous feedback. We sent all of them a home spirometer device, and again, building an automated chatbot pathway with our partners at Conversa, deployed to the entire program a monitoring program that incorporates both checking on their symptoms and their home spirometry data. And we now have more than 2/3 of the participants in the lung transplant program are using this regularly. And we've started, again, thinking about the opportunity presented by COVID to accelerate a pre-existing trend where people might have wanted more care delivered at home and in a low-cost environment, rather than people coming into a pulmonary function testing lab every 3 months for a arduous and expensive test. They're monitoring their symptoms regularly at home. And the correlation that we've seen in terms of the home measured pulmonary functions and the laboratory measure are very high. And so now our patients who are in this program have been very grateful that they can continue to check up on themselves regularly at home with lower costs without having to come in all of the time, many of them from hours and hours away from UCSF. And we actually, in one case, anecdotally, were able to pick up an early case of lung decline and potential lung rejection, transplant rejection, which is one of the things that we're really looking for here. And so the opportunity here is higher patient engagement, more feedback and peace of mind for the patients, and doing it in a lower cost setting. And ideally, as Murray was talking about, allowing the doctors to practice to the top of their license. So rather than the providers being the one who are having to ask these very routine standard questions all of the time, being able to manage people when they need it, and to triage people who actually need more intensive care into the more intensive care when they need it.
Great example. So let's jump over to South Carolina. So Dr. Patel, tell us what's happening there.
Jen, thank you. Great to be here. Well, just like most healthcare systems, we had to pivot quickly as well. And if all of us remember, in the early stages of COVID, data was changing, information was changing on an hourly basis in regards to how you catch it and what the safety protocols need to be. And people were scared. And we started to get a lot of cancellations for our office visits, our routine visits, both ambulatory and surgical. And like most health systems, we stopped elective procedures as a precaution for the safety of our citizens. And so we pivoted almost over a weekend to go to virtual ambulatory care. And, you know, we probably did around 22,000 virtual visits last year. As of right now, we've almost done 500,000 since March. And we wanted to do that. A lot of it is make sure that we didn't have patients exacerbate their chronic disease and end up in an emergency room or admitted where we didn't want them. And but as you can imagine, with something such as a pandemic, it has its challenges in regards to the number of patients that needed care or had questions, and you needed to be able to give them information that was singular, not varying. So we set up an incident command center that all communication came out of, so that information both for employees as well as patients we're all singing from the same sheet of music. And automation and work that we did with Conversa really helped with that. So the couple of chats that we did with them early on was, number one, a COVID screener chat. And I think as of yesterday, I think I saw almost 200,000 engagements with that in our state. And essentially, it let patients who had questions around COVID, if they had symptoms or should they get checked, should they get tested, you know, either they fell into a green box and said, yeah, you're healthy and here's how you stay healthy, or you fell into a yellow box. Well, you have some symptoms of COVID, but you also could have something else, or you really have all the primary symptoms of coronavirus. You should get tested, and here's where you go get tested based on the zip code that you entered in your chat. So we started with that, and we had great uptake with that. And the contact centers really loved it because they got less calls, because they were able to route people without having to call and go over the same symptom questions that everyone has to ask. Then we moved over to actually a lot of colleges later on started to come back online, and a lot of colleges you started to use ours for return to school chats. And then we used the same thing for our own employees. We had 30,000 employees, and you can imagine having someone at the entryway of every ambulatory center, 330 ambulatory centers and 18 hospitals. I mean, by the time you ask the fifth or sixth person that question, they're pretty much going to go, are you okay? They're not going to go through primary symptoms of coronavirus, of cough, shortness of breath, fever, or exposure. And so the digital badge really allowed us to do that, where you show your badge, it's timestamped with your name, it decays in 12 hours, and then you rinse and repeat the next day. But sorry, Jen, I can't hear you. I think you're on mute.
Sorry, can you just describe that a little bit more, the digital badge?
Yeah, the digital badge essentially is like a pre-screener. So before you come into work, at certain entry points, you would actually do the screener on your smart device. And we had a unique code for Prisma where our employees would go, and then it would actually fill out essentially do the chat. And if you pass the chat, then you would show a green badge. If you had a yellow badge or a red badge, you would then go to our business health and our employee health to then get tested or get further care if you needed it. So it's been very successful, and our employees really enjoy that, because instead of having to stop and get a little sticker that goes on your badge, and which ends up being 30 stickers after a month, right? I mean, it doesn't make sense, and it's hard to keep track of which sticker is active that day. But the badge allows us to do that. Plus, on the back end system, we get the data, so we know which patients our employees are doing well and which ones need additional care.
And you mentioned this is being used by a lot of schools, which I just want to highlight for folks as well, the digital badge. So it really applies across other industries. So
yeah, we have a couple of universities here that are interested in using it and have been very successful, and they've given us great feedback. And now they want to look into how do we start to shift chats to wellness and well care, mental wellness as well. As you know, depression, anxiety has gone up significantly during this time. And so how do you start to automate that? And to me, I think, and to what Murray had said, and as well as Aaron, it's about taking the robot out of the human. And we as physicians all do repetitive activities a lot. And automation is truly what's going to get us to what I consider healthcare 3.0. 1.0 was paper charts and pre-EHR, and then 2.0 was EHR, and then 3.0 is adding automation and some robotic processes that are actually going to happen behind the scenes, kind of pulling on the lever of evidence-based medicine and standards of care that we all practice to get out variability, and as well as to recognize disease early. As Murray mentioned, we're doing a huge project around remote patient monitoring around chronic disease management of hypertension, diabetes, and heart failure. Aaron's state of California does not have as much heart disease as we do. If you look at the CDC map, diabetes and heart disease are very prevalent here in the Southeast, probably because we have really good fried chicken and good Southern food. But, we have a lot of things that we have to take care of. And we have to get out of this mindset of the only time you get care is the 15 minutes of FaceTime, if that you get with your provider. Mm-hmm. And it's part of those digital points and nudges and check-ins by a robot and using evidence-based medicine and data coming in through wearables that get people to their goals when it comes to fitness, to blood pressure, to diabetes, etc.
Let me ask Peter, actually, or Dr. Pronovost, excuse me, to pick up on the item that you mentioned there about doctors turning into robots or robots replacing. I want you to talk about the automated care manager bot and explain what that is, Dr. Pronovost, and share that.
Sure. Thank you so much. I can show you, if you can see on my screen, and I was from my clearance earlier, but Jen, let me just kind of build upon these great presentations. You see, what I think you've heard from them is COVID created, as Dr. Martin Luther King said, the fierce urgency of the now. You see, prior to COVID, I would say most innovation was what I would call innovation theatrics. We were doing a whole lot of prediction models, but there was no intervention applied to it. And for the most part, there really wasn't any real impact. And COVID forced us to not just do innovation, but to make sure that it really works. And COVID coupled with this concept of what we call defects in care. So that this defects in care are resulting in a $1.4 trillion of waste. And we group them into preventative care, staying well, getting well, chronic disease management, and getting better, acute care management. And what you've seen in our work and the others is we've automated virtual care in all three of those domains. And what we're seeing, Jen, is what's really accelerating this improvement is combining multiple types of technologies. And because once we built this integrated database, what we've been doing is trying to integrate three technologies to automate chatting or smart chatting with the Conversa chatbot, which is running ML models to find at-risk patients for any one of these defects, and then scheduling of getting people care. So to give an example, we know around the country 37% women will get.
Peter, we're having a little trouble hearing you. I think you're pixelating a little bit on us. Okay. Let's see. It looks like he's moving around. To better cell location in the office. All right. We're getting a lovely tour of Dr. Pronobos.
Who's his ISP?
I
Yeah.
know.
Okay. There we go.
Oh,
There we go.
is that better?
Yeah. Okay. All right. You know, let's switch it. Let's switch gears a little bit, Peter. I think we're having, maybe Peter, you could call in because I think we're having a little trouble with your line. Okay, let's just switch over a little bit, talk a little bit more, which I think Dr. Pronovost is getting at, is all of these, you know, we're doing this much better now because of COVID. COVID's kind of forced us the urgency of the right now in terms of these different organizations and really forcing us to think about asynchronous care and automated virtual care. Murray, pick up on this a little bit if you could.
Actually, hopefully we'll get Peter back here in a minute, but I encourage everybody to read his paper which was published in the New England Journal of Medicine. He was talking about automating the interaction with the patient, which we talked about, and then automating what he's called the trigger, so the ability to identify a patient through machine learning and AI to identify a patient that needs triaged. And then the third is smart scheduling. Where do they actually need to go? So those are the three areas that the paper that he published with a number of other colleagues, New England Journal of Medicine, to address this 1.3 or 1.4 trillion dollars of healthcare spend that they're calling zero defects. Another way we think about it was very interesting. When I read that, light went off because you just heard it from Nick and from Aaron. If you could get everybody on an evidence-based pathway, right? So we have lots of evidence, and the evidence is around correlating behaviors with outcomes. So people know what the behaviors and the interventions are that drive the outcomes we want, but all that evidence is not practiced at the point of care. There's lumpy access to the evidence. There's a lot of variability of care because of that. So one of the things you can do in an automated pathway is reduce that variability completely and have everybody down an evidence-based pathway. The likelihood of getting the outcomes you want is much higher. And you can address that $1.4 trillion. You can address getting better outcomes. The problem is getting everyone on that pathway is engagement. How do you get patients to actually do that? Because one size doesn't fit all. So what we're trying to do, and actually the way I talk about what our goal is at Conversa a lot of times, is reducing variability of care through getting everybody on an evidence-based automated pathway, but increasing the variability of engagement, which is personalization. That's not an easy trick. How do you make sure that everybody's getting the right guidelines that we know are evidence-based, but do it in a way that, Jen, you would resonate differently than Peter, than Aaron, than Nick, so that you actually change your behavior and move in the right direction. So that's really where we're spending a lot of our time. I love the way Peter, when I saw it, I said, wow, we're talking about the same thing in very, very different words, but it was the same problem.
Great. Peter, Dr. Pronovost, let us know when you're dialed in so we can bring you back here. Dr. Patel, can you pick up on this a little bit?
Yeah, I mean, it's also the changing times. The way we get reimbursed and our population has changed as well, right? So just putting COVID aside for a little bit, I mean, we were already on that pathway to form a digital health continuum because we have a large number of patients at risk that we're on contract for, as well as we see a major shift in population and what their needs are. For example, the millennial population's outnumbered the baby boomer population. And they're on a very on-demand sort of, retail experience is what they're looking for. So you also have to change his mindset of just overall in healthcare, that of a patient versus a customer or consumer. And a consumer wants easy access, frictionless access, and they want to be engaged. And how do you engage them? Well, most of us, as you know, we're all used to using cell phones, and especially the millennials and Gen X's and everyone else. And so being able to ask a question and get a automated bot that gives you evidence-based data on your next steps, or understands and ingests information about your symptoms, and then goes through an evidence-based algorithm to spit you out to where you need to be seen. Either let's set up a virtual visit, or let's actually continue this conversation, but instead of an automated chat, I, as a doctor, have checked in, and now I'm talking and texting back and forth. As a physician, I bet you my colleagues have had this happen as well. You get texted by our friends and family all the time. Hey, I got this problem, or here's a picture of this rash, or what do you think's going on? Well, most of the time I just text back, do X, Y, Z, or I don't think it's anything, or I think you should get seen for that. And so, we could potentially do that, but if you need to escalate it again, click a button, let's do a video visit.
Right. Dr. Patel, how do we make sure all that stuff gets captured? Because we do hear back from clinicians that, they send you a picture of the rash, you tell them what to do, but then it gets lost.
Well, that's the secret sauce of all of this, right? And so you got to connect it. In order to be a continuum, you have to be connected. And foundationally, the data must move from all those boxes that Murray showed you earlier, from one to the other and back and forth. And it needs to go into your master record, your health record, your electronic health system, so that if other providers see that same patient, so Aaron's an endocrinologist, I'm a primary care doc, let's say I send someone to him, well, he should be able to see what I did. It's okay, Nick Patel did this, and okay, I'm going to take it from here. And so the data flow has to be there. And I think, especially with, with all the changes in regulatory, we also have to be now transparent 100% with data to the patient, right? What Aaron said about a person, or what I said about a person, so that they actually can see and share maybe with family members. And I think that's the beauty of what we're moving when it comes to digital health, is that you can bring in other family members. As part of COVID, I had family members as part of the video chat, looking and talking about mom and how she's doing and things of that nature. So it was more engaging, because sometimes transportation issues will occur where a patient misses an appointment, or a family member can't be part of that appointment because they're working. So I think you have to give people choice. And that's the key here. It's not the only choice is not just come see me in the office. There are other avenues to see a provider and get care. And I think that's what's going to help us move the needle, because what we've done before is wait for people to get sick or come to an office visit and then take care of them, versus proactively keeping them healthy or engaging them in their chronic care management every day.
I love that. I love that idea. Dr. Pronovost, why don't you pick up on that a little bit?
Yeah, that's exactly right. I mean, we spend so much time wasting people's time, bringing them into care and settings that it's not convenient for them or for us. And I apologize for the bandwidth issue. I had gremlins. What we're seeing is if you combine a number of technologies, so in our case, chatting with Conversa, triggering, so ML rules to identify at-risk populations, and scheduling or smart scheduling, where you can schedule visits or transportation, we could eliminate so many of these defects. I'll give you an example where now we could take diabetes care, and I'm cautious because Aaron's an endocrinologist, but we know 40% of diabetics aren't diagnosed. About 8% are on the newest medicines they should be on. 7% have their A1C, their lipids, and their blood pressure control, and 80% have avoidable hospitalizations. So what we've done on the patient side is combining those three capabilities to outreach to people who say, hey, you look like you might, you've had some high lab values. Here's diabetes. Want you schedule here to make an appointment. For those who aren't controlled, we have a chat to explain what is control and what it should be. And again, get them plugged into to care. We're also using this technology, Jen, to augment the productivity of physicians, because what we found is that access to specialists like Aaron or behavioral health are really challenging. And we started about thinking, how do you organize specialist care around people's needs, not around the big toe specialist? And what we found is that the reality is 80% of those needs could probably be met by up to 1 to 3 consults. They don't need long-term care often. Some people do, but most people just need to have some questions answered. So we started this access clinic for endocrine, for behavioral health, but now we're automating that and again, triggering and scheduling. So when a primary care doc says, I have this diabetes question, they put it in a chat. There's a logic that says, okay, you may want to consider this. And then there's the option to say, okay, no, I want to talk to the specialty consultant, still get them to me. But there are all kinds of ways to grow productivity through these things. A final thing I think that Nick, so eloquently said is we also can link these kinds of things with navigation to telehealth or other things. So patients might start with chatting or do something and then say, I'm not pleased with that, or I'm still worried. Could you connect me to a nurse navigator? Or could you connect me to a televisit that I can speak to someone? And the ability to integrate these technologies, I think offers us such hope for eliminating many of those $1 trillion in defects.
So Dr. Pronovost, how are you getting patients to start using these systems and doctors to start using them? I mean, the adoption,
Yeah.
I mean, we know there's an urgency, but there's always concerns about privacy and just unfamiliar.
Yes. So Jen, you make a great point. And it's what Murray and our Conversa team were discussing. I think a big phase of this journey is now evaluation and continue engagement. And so what we've literally just deployed is for each of those 3 types of use cases where the defects, that is the preventive care, chronic care, and then the acute care, like we're using for many types of surgeries before and after, standardizing what that evaluation pathway for eliminating defects. So let me give an example. For many of these, it is, okay, did the patient even agree to get the chat? If they did they engage it for how long? If they did any measurable behavior change, right? Whether that's A1C control, did they get access to care that they might not have otherwise? And then ultimately, did they reduce or improve their value? So in our case, reduce avoidable utilization or reduce annual total cost of care. And so each one of these, it requires standing up a cohort of patients that we could look at how those who get Conversa perform compared to a similar cohort of, in this case, diabetic patients who don't use Conversa. So we again, so that we really understand what's driving value for this. So it's not just a shiny object, but at the end of the day, we eliminate these defects in value or provide better care for the people we are serving.
Let me shift the discussion a little bit away from chronic care and immediate care delivery. Let's talk about vaccinations, because this is kind of the next frontier in terms of COVID, but we're talking about really having to scale tremendously. And I would imagine that, automated virtual care can play a big role here. Peter, do you have any thoughts on this?
Yeah, you're absolutely right. I mean, if you think about what the logistics of this vaccine, there's and the rollout and the speed of developing it has been nothing short of breathtaking. It's something the country should be really, really super proud of. I mean, it's an amazing success story, but now we have to go deploy it. So think about all that we need to do, that things like Conversa or smart chatting and smart scheduling could be. One is just asking our employees and our patients the myriad of questions about what's the difference between the 3 vaccines, or assuming all 3 get FDA approved, which one is right for me? Do I get to choose? Where do I go to get these things? We are right now consuming, so many human hours of answering the phones for just our staff, and our practices are asking patients. All of that could be done in a chatbot. I think we could then we will use scheduling through this. So we could outreach to someone through a chat, click here when you want to get your vaccine. Here's where you go, the nearest place to you. And here's where you could, your time slot for the vaccine. So we will be using these technologies to significantly improve our productivity. We'll be combining it with geolocation so that it could actually, we can say, oh, the nearest clinic where you can go is here, right? I mean, just like we do in every other industry, we just haven't combined these kind of things. And that, none of these are really new technologies. We're just combining them in ways that are accretive to value that we give people. So we're quite excited. You'd appreciate this. We're also pilot testing a technology called Trackonomy that does all the logistics for UPS. It's literally putting a piece of duct tape on whatever you want, an infusion pump, a pallet of vaccines, so that we could see in real time where they're being distributed to across our health system. It's truly like just some really innovative stuff going on in this space.
I love this. So Dr. Neinstein, Dr. Patel, jump in here and tell us what you're seeing in terms of, these tools being used around vaccine distribution. Hopefully you guys have it at your hospital this week as well.
Yeah, I mean, the automation of this is key from a logistics, but also education, because all three of these have a little bit nuances that are different. From the time you get the shot to actual immunity is different between the Pfizer shot and the Moderna shot. And so you have to educate patients. You have to also educate them on what the most common side effects are and the reporting of it. Right. And so, but the other piece is, how do you use automation to do a digital badge for that you got both vaccines, so that when you go to a restaurant or you go to a large event, that you show this, or you get on an airline, hey, I've been vaccinated, but that data is validated with your state health department, et cetera, so that there's maybe a QR code or things of that nature. I know that Murray and the team are out of box thinkers and are already working on this and have given a slight taste of this already, but this is going to be really important. You might have seen Clears doing this, Ticketmaster is doing these sort of things. So it's the logistics, there's the education that needs to be, again, standardized so that people get the right information that is given out by the CDC and the FDA instead of social media. Right. We want to make sure people don't think they're going to turn into zombies because they take a vaccine. We need to give them encouragement. Right? Hopefully we don't turn into the movie I Am Legend, but this is there's a lot of fear out there because how fast the vaccines came out. But physicians as a whole have been so pleased with how efficacious these vaccines are. It's unfounded. So I think automation and chatbots are going to help with this greatly, not only now, but into the future.
Great. Let me also just let folks know we are pushing out through the chat box here. Dr. Neinstein talked earlier about this lung transplant virtual care program. So we're pushing out a link so you can learn more about that. Sarah, if you could push that out. We've also got a link on the New England Journal of Medicine paper Dr. Pronovost has, and he's spoken about that today. And then there's also an ebook on virtual health awakening. So you're going to see those links. Sarah, push those out to everybody while we're talking here. I just want to make sure everybody's got those resources there. Go ahead, Dr. Neinstein.
Yeah, sure. I'd love to build on what Peter and Nick are saying, which is there's, I think, agree completely with everything they're saying. And there's, I think, three thematic opportunities that we should be seizing on here. So one is we're talking about standardization and automation. I think the next layer to that, as we get frontline providers out of the business of just repeatedly saying the same thing over and over about a vaccine, is to start personalizing it, right? So at all of our healthcare centers, we've got populations of people with diabetes, people with rheumatoid arthritis, people who have had transplants. And so once you start building these automated tools, you can start adding in little bits of personalization for individual populations of people who might have a slightly different set of questions or interests or concerns than sort of all of the same information for everybody on a static website, right? So if you put vaccine information up on a website, everyone sees the same thing, and they're still going to have questions because they're going to say, well, I'm on this medication for my rheumatoid arthritis or my diabetes, and does this apply to me? So I think having these bots and personalizing them is one really important piece. The second is integration. So I think there have been some questions and people were talking about, how do we, and Nick was talking about, how do we get this information to flow back into the EHR? I think this is the moment to seize on. The 21st Century Cures Act is being implemented by the ONC right now. And so there are increasingly standards leveraging technologies like Smart on Fire to integrate the different tool sets together. And what a perfect opportunity while we're in the midst of the greatest, public health emergency, hopefully in our lifetimes, to really have a moonshot as a country and to start leveraging the standards and start integrating together our public health system, our traditional care delivery systems, patient-facing tools and patient engagement tools, and start connecting those data together. Because if this isn't the imperative to do that, I'm not sure what will provide the imperative for this country to start really integrating those tools together. And then I think the third is taking the opportunity to measure, which Peter was talking about. We're in this new moment where COVID has sort of forced people to accelerate the development and implementation of these tools. And there will be a lot of questions about, are these tools high value? Do they work? And so measuring what we're doing now will provide us the opportunity later to have meaningful conversations with the payer community and at a policy level to say, yes, this stuff really does work, because we're kind of in a natural experiment right now.
So let me just follow up on that. We've got a number of questions in the question box, and I want to get to them. And one of the questions actually, Dr. Neinstein, is about metrics. Are any of you using metrics to kind of assess or measure if there are changes in behavior because people are using this automated care or some of these tools? I think, Peter, you kind of alluded to that, but are there metrics?
Yeah, I sure. So yes, there are. I would say we don't have a standard evaluation framework yet. So each one's, but so a couple things. Obviously for our diabetics, we're looking at their A1C levels and if those levels change compared to others, and also avoidable utilization, so ED visits and hospitalizations compared to a population of diabetics who don't have, who aren't getting the chat right now, or the combination of chat and triggering and scheduling. Some of the things are simpler, like the preventive care, colorectal cancer screening and immunizations are relatively straightforward. Do they get that task? Chronic disease are a little more complicated. And then on the acute care side, we're looking at preoperative education for some of our surgical patients. And so we have some surveys in that. And then the post-op, it's largely looking at readmission rates. But, to build on what Aaron said, one of the, I think, ripe areas for research in this area is combining kind of the informatics and the epidemiology with behavioral economics and sociology, because so much, as you alluded to, Jen, of getting people to use this isn't tech, it's economic incentives, it's sociology, it's psychology, it's because it's literally about behavior change. And
Right.
I think what we're going to see innovation accelerate when we kind of put those groups of research teams together to think about this from a more holistic perspective.
So another question we've actually gotten here, Murray, is around, is virtual care, how do we make this really accessible at a low cost? Because I would imagine cost is an issue for some, and does this help eliminate barriers for patients in any way? Could you talk about the cost issue a little bit?
Yeah, and I'll tie it together with a couple of comments that were just made by Peter and Aaron. So yeah, I would say, generally speaking, the marginal cost for adding an additional patient is extremely inexpensive, if not zero. So it's designed, that's one of the key hallmarks of this is, and we encourage our health system partners to think about it as a population health tool, put everybody on the platform, even if they're healthy, or if you have a diabetic population and you have some that are low risk. One of the big pieces of value here, and Peter talked about it, is that second piece, that triggers. It's constantly, because it's reaching out so frequently and engaging in a relationship, it's constantly doing real-time risk stratification all the time. And so the whole idea is identifying low-risk patients that are becoming rising risk and rising risk becoming high risk. So the whole idea is it is designed to be low cost so you can use it for a whole population, and then get those patients that actually need the higher cost connection triage to that higher, different care venue that's required for them just at that time it's required. And I just thought just two other quick things because it was interesting. The behavioral piece, critical to the whole thing. We even think about this platform. We embed behavioral science in the platform. So it's collecting data and then deciding what's the next best step. Can it be automated? But the automated next step is all about getting the patient to continue down this evidence-based path by exhibiting the right behavior. So if they're off track a little bit, the whole idea is how do you nudge them back on track? So there's a lot of behavioral science in the platform that's designed to do just that. And then on the vaccine, I think where it's relevant, and we heard some of it, 30% to 40% of the population is saying they're not going to take the vaccine or they're unsure. Right. So educating them as to why and understanding the risks. And then as Aaron talked about, right now it's pretty generic, but people are going to segment out, if you're in a high risk category, we don't have enough data yet to know what the implications are for you. How long does immunity last? Are you still able to transmit the virus even if you have the vaccine? So reinforcing, you still need to mask and distance and screen even when you get it. So there's just so much information required. Nick talked about it before. There's awareness, there's education, and then there's the distribution. How do I get it? Where do I get it? So part of this is around personalization, as Aaron talked about, and guiding people. Part of it is about allaying anxieties and getting people to take it so that we can get to herd immunity. And then there's, as information becomes available, how do we update people's notion of where they are? And of course, this is, we're starting with the healthcare workers have very different needs, and prioritization, who gets it when. I mean, that's an urgent need. So we're working, as Peter, Nick, and Aaron said, with all three of these systems. We actually are launching this week the vaccine program with another partner, and we've combined it with the remote patient monitoring, because what we do is kind of a superset. So there's a device that's going to basically monitor side effects, as Nick talked about, for high risk patients that are getting the vaccine. So they'll be able to check in, and it'll also be collecting very high frequency vitals to be able to swoop in if something goes wrong.
Hey, Jen, can I just follow up on that question? Because I think it's important for the audience or for us to explore the impact of technologies on health inequities. I mean, as you all are aware, at least in my view, there are morally unacceptable degrees of health inequities in this country. And on the one hand, tele and these digital tools have the potential to minimize those because they could expand access. But that's conditioned on people have knowledge of how to use these, that they have broadband access, and they have a device. And it's really telling for us in Cleveland, because Cleveland just was, recognized as, I think, having one of the worst or amongst the worst access to broadband in the country. But in many urban areas, 50% of the people don't have access to the internet, and
right.
At least 40% don't have a smart device or a computer. And so there's these zip codes that there's digital inequities that will worsen health inequities. And I think as a group, as thought leaders like these brilliant people on the call and public policymakers, we have to see how to begin to address that.
I think that's such a great point there. And we're at the top of the hour, so I want to give everybody kind of a quick opportunity to help us close here today. This has been a fantastic discussion. Everything's been very, insightful perspectives. Appreciate everybody's. But as we kind of wrap up this year and move forward, I'd love to hear from you. Adopting these technologies is difficult. We've seen some questions about, what do you do when there's technical issues? The whole implementation and kind of going live with this automated virtual care, certainly there's an urgency to do it, but we know it's also a tough thing to go through adoption. So what would be your words of wisdom that you would give to other providers and folks trying to adopt these technology? And I'd love you to do it in 10 words or less. It's going to be the hard part. Or just, what's the first thing that kind of comes to your mind in terms of kind of what advice or wisdom would you give to other folks as they move to adopt these things? And anybody who wants to go first, go for it.
I would say start with the problem, not the technology.
Great. Super. Who's next?
Find the initial use cases that drive ROI and then build from there.
Okay.
Yeah, and I would add, I think for me, there's three things. Focus on the problem or the defect in value. Engage either clinicians or patients to test the usability, and then get partners, because you're not going to do this alone.
And great. And Murray, why don't we wrap with you?
Yeah, I agree with all those. So I'll add with an analogy. So when people look at self-driving cars and there's an accident on the road, and it's not clear whether it's due to human error or not, there's a backlash to say that this is technology that's not ready, and it's not fair to compare it. It's not right to compare it to zero accidents. There's 1 million people around the world that die every year in traffic accidents. So my advice here is compare it to what you're doing now. I agree 100% with Peter's point about access. But if we look at how much we're spending, and we were able to take the savings from virtual health that Peter's paper talks about, $1.4 trillion, and took any percentage of that and just investing it on helping with the access problem, we would dramatically improve access and care and outcomes and everything else. So I think we have to think about it differently.
Great. Thank you. And thank you again to Conversa, and thanks to our stellar panelists today. Incredible discussion, wonderful insights. Appreciate everybody joining us and hanging on with us. The materials are available online. The links are there, or you can go to the website eidc.org and pick up all of these things. Thank you, everybody, and have a wonderful and safe day.
Jen, excellent job.
Thanks, everybody. Thanks, Jen.
Thanks, everyone. Thank you.
Yeah.